Hello, and welcome to the best sleep aid on social media, where you'll drift off while learning fundamental emergency medicine knowledge. These boring medical fact episodes cover key principles that every emergency physician must master before stepping into the ER. By the end of this series, you'll either know more about emergency medicine or simply wake up refreshed, having absorbed knowledge passively. Each episode focuses on a vital concept or condition relevant to ER practice. If you enjoy this, please share it with your friends and subscribe for future episodes. If you don't, just be sure to minimize how much you scroll and search to reduce your exposure to blue light. Now, let's set the stage for deep, effortless sleep. Dim the lights, place the screen of your device face down, and set your room temperature below 75 degrees Fahrenheit, preferably under 70 degrees for ideal rest. Whether you prefer silence or white noise, ensure your space feels comfortable. Before we begin, we'll do a simple breathing exercise to slow your pulse and prepare your body for deep relaxation. Inhale for a count of 4. Hold for a count of 4. Exhale fully for a count of 8. Pause for a count of 4. We'll repeat this 3 times. Feel your pulse slowing with each breath. Ready? Begin. Inhale. Hold. Exhale. Pause. Inhale. Hold. Exhale. Pause. Inhale. Hold. Exhale. Pause. And relax. Let's begin tonight's episode. Airway, Part 1. Imagine yourself in an emergency room on a typical shift, and a paramedic call comes in. The case is a 72-year-old male with a history of CHF and COPD is brought into the emergency department by paramedics due to severe respiratory distress. He was found struggling to breathe at home with increased work of breathing, accessory muscle use, and audible wheezing. Pre-hospital intervention included initiation of BiPAP with 100% of FiO2, leading to an improvement of oxygenation and saturation to 90%. Upon arrival, he remains tachypnic, diaphoretic, and anxious, with diminished breath sounds and bilateral crackles on auscultation. He is hypertensive with an elevated heart rate and JVP distension. His clinical presentation suggests concurrent COPD exacerbation and acute on chronic CHF, possibly triggered by fluid overload or infection. How do we go about managing this? Let's begin. A decision to intubate should be based on 3 essential criteria. 1. Failure to maintain or protect airway. 2. Failure of ventilation or oxygenation. And 3. A patient's anticipated clinical course and likelihood of deterioration. 1. Failure to maintain or protect the airway. A patent airway is essential for adequate ventilation and oxygenation. If the patient is unable to maintain the airway, patency must be established by artificial means such as repositioning, chin lift, jaw thrust, or insertion of an oral or nasal airway. Likewise, the patient must be able to protect against aspiration of gastric contents, which carries significant morbidity and mortality. Traditionally, presence or absence of a gag reflex has been advocated as a reliable indicator of the patient's ability to protect the airway, but the gag reflex is absent in 12 to 25% of normal adults, and there is no evidence that its presence or absence corresponds to airway protective reflexes or the need for intubation. A more reliable indicator may be the patient's ability to swallow or handle secretions, but this also remains to be tested. The recommended approach is to evaluate the patient's ability to phonate, the level of consciousness, and ability to manage his or her own secretions. In general, a patient who requires a maneuver to establish a patent airway or who easily tolerates an oral airway probably requires intubation for protection of that airway, unless a temporary or readily reversible condition, such as opioid overdose, is present. 2. Failure of ventilation or oxygenation. Ventilatory failure that is not reversible by clinical means or increasing hypoxia that is not adequately responsive to supplemental oxygen is a primary indication for intubation. This assessment is clinical and includes evaluation of the patient's general status, oxygenation by pulse oximetry, and changes in the ventilatory pattern. Continuous capnography also can be helpful, but is not essential when oximetry readings are reliable. Arterial blood gases, or ABGs, generally are not required to make a determination regarding the patient's need for intubation. In fact, they can at times be misleading. Regardless of the underlying cause, the need for mechanical ventilation generally mandates intubation. External mask devices increasingly have been used to provide assisted mechanical ventilation without intubation, but despite these advances, most patients who need assisted ventilation or positive pressure to improve oxygenation eventually require intubation. 3. Anticipated clinical course. Certain conditions indicate the need for intubation, even in the absence of frank airway, ventilatory, or oxygenation failure. An example of such a condition is severe cyclic antidepressant overdose. Although the patient is awake, protecting the airway, and exchanging gas well, intubation is advisable to guard against the strong likelihood of clinical deterioration, which can occur relatively abruptly and includes coma, seizure, cardiac dysrhythmia, or arrest, and possible aspiration of activated charcoal or gastric contents. Another example would be significant multi-trauma. Although these indications for intubation may seem quite different and individualized, the common thread is the anticipated clinical course over time. Knowledge of the natural history of the emergency condition is essential to determine whether intubation is necessary when airway compromise or gas exchange failure is not present on evaluation. A similar thought process is applied to any patient who will be leaving the emergency department for diagnostic studies or who may be transported to another facility. If it seems clinically likely that the patient may deteriorate, prophylactic or preemptive intubation is the prudent course. After you've made the determination that intubation is necessary, the next step is to identify a difficult airway in order to make necessary preparations for intubation failure. In most patients, even in the emergency room department's precipitous and unpredictable environment, intubation is technically easy and straightforward. In a large emergency department study, overall intubation failure rates are about 1% for medical intubations and less than 3% in trauma patients. Intubation failure occurs in approximately 1 in 200 to 1 in 2,000 elective general anesthesia cases. Bag mask ventilation, BMV, is difficult in approximately 1/3 of patients in whom intubation failure occurs, but combined failure of intubation and BMV is estimated to be exceedingly rare, 1 in 5,000 to 1 in 200,000 elective anesthesia patients. These numbers cannot be applied directly to the emergency room department situation, but are reassuring in that they indicate a high degree of safety if pre-intubation analysis of factors predicting difficult intubation are undertaken. In other words, preparing for a difficult airway. Neuromuscular paralysis should be avoided in patients for whom a high degree of intubation difficulty is predicted, unless the administration of NMBAs is a part of a planned approach to the difficult airway. This approach may include use of a double setup in which an alternative approach, such as cricothyrotomy, is simultaneously prepared for. Pre-intubation evaluation should be as comprehensive as clinical circumstances permit. A systematic approach to the patient is required. Most of the difficult airway markers discussed in the anesthesia and emergency medicine literature have not been scientifically validated. Nevertheless, a methodical approach can be used to evaluate the patient based on the accepted markers of difficult intubation. One such approach uses the mnemonic LEMON, L-E-M-O-N. L stands for look, E, evaluate, M, malampati, O, obstruction, N, neck mobility. L, the look, mostly refers to gestalt. Most experienced physicians can simply look at a patient and determine, based on their experience, whether the intubation will be difficult or not. Gestalt alone has a specificity of greater than 90%, but a sensitivity of less than 20%. During this look phase, you may also determine how difficult it would be to perform bag mask valve ventilation, as well as a cricothyrotomy on a patient. There are some key features that determine whether a patient will be difficult to perform BMV on. The mnemonic for this is MOANS, M-O-A-N-S. M stands for mask seal, O stands for obesity, A stands for aged, N stands for no teeth, S stands for stiffness or resistance to ventilation. A difficult cricothyrotomy can be anticipated whenever there is disturbance of the ability to locate and assess the landmarks of the anterior airway via the neck. Prior surgery, the presence of hematoma, anatomic disruption, tumor or abscess, scarring or obesity, edema, subcutaneous air, each has the potential to make cricothyrotomy more difficult. The landmarks for cricothyrotomy are sought and identified as part of this first step in assessment of the difficult airway. That completes the L for the LEMON mnemonic. The next letter in the LEMON mnemonic, E, stands for evaluate. Specifically, evaluate 332. Direct laryngoscopy requires the ability to visualize the glottis by direct vision through the mouth using alignment of the oral, pharyngeal, and laryngeal axis. Visualization requires that the mouth open adequately, that the submandibular space be adequate to accommodate the tongue, and that the larynx be positioned low enough in the neck to be accessible. These relationships have been explored in various studies by imaging and by external measurement of thyromental distance. The 3-3-2 rule is an effective summary of these geometric evaluations. The 3-3-2 rule requires that the patient be able to place 3 of his or her own fingers between the open incisors, 3 of his or her own fingers along the floor of the mandible beginning at the mentum, and 2 fingers from the laryngeal prominence to the floor of the mouth. The patient with a receding mandible and high-riding larynx is virtually impossible to intubate using direct laryngoscopy. Most patients are not sufficiently cooperative for such an evaluation, and the operator compares his or her fingers with the patient's finger to estimate the sizes for the 3 tests. M for Mallampati score. Oral access is assessed using the Mallampati score. The Mallampati score is divided into 4 classifications, Class 1 through Class 4. Class 1, the operator will be able to visualize soft palate, uvula, fossas, and the tonsillar pillars. In Class 2, soft palate, the uvula, and the fossas are visible, but the tonsillar pillars are not. In Class 3, soft palate, the base of the uvula is visible, but not the tip of the uvula. In Class 4, the hard palate is the only thing that is visible. Class 1 and Class 2 predict adequate oral access. Class 3 predicts moderate difficulty, and Class 4 predicts a high degree of difficulty. O for obstruction. Upper airway, or supraglottic, obstruction may make visualization of the glottis or intubation itself mechanically impossible. Conditions such as epiglottitis, laryngeal tumor, Ludwig's angina, neck hematoma, or glottic polyps can compromise laryngoscopy, passage of the endotracheal tube, and BMV or all 3. Physical examination for airway obstruction is combined with assessment of the patient's voice to satisfy this evaluation step. N for neck mobility. Neck mobility is essential to allow the angled access of the upper airway to be sufficiently repositioned to permit direct visualization of the glottis, and is assessed by having the patient flex and extend the head and neck through a full range of motion. Neck extension is the most important motion, and simple extension may be as effective as the sniffing position in achieving an optimal laryngeal view. Modest limitations of motion do not seriously impair laryngoscopy, but severe loss of motion may render laryngoscopy impossible. Cervical spine immobilization and trauma artificially reduces cervical spine mobility and predicts a more difficult laryngoscopy. But direct laryngoscopy is still highly successful in this group of patients. Identification of a difficult intubation does not preclude use of an RSI technique. The crucial determination is whether the operator judges that the patient has a reasonable likelihood of intubation success, despite the difficulties identified, and that ventilation with a bag and mask will be successful in the event that intubation fails. Hence, the value of the MOANS assessment, MOANS. As a review, MOANS stands for mask seal, obesity, aged, no teeth, and stiffness, or resistance to ventilation. Conformation of endotracheal tube placement. The most serious complication of endotracheal intubation is unrecognized esophageal intubation with resultant hypoxic brain injury. Although direct visualization of the ETT passing through the vocal cords is generally a reliable indicator of tracheal intubation, such clinical anatomical observations are fallible, and additional means are required to ensure correct placement of the tube within the trachea. Traditional methods such as chest auscultation, gastric auscultation, bag resistance, exhaled volume, visualization of condensation within the ETT, and chest radiography are all prone to failure as means of confirming tracheal intubation. Other clinical techniques are readily available for detecting tracheal or esophageal intubation. Immediately after intubation, the intubator should apply an end-tidal carbon dioxide detection device to the ETT and assess it through 6 manual ventilations. Disposable colorimetric end-tidal CO2 detectors are highly reliable, convenient, and easy to interpret, indicating adequate CO2 detection by color change. The colorimetric end-tidal CO2 detector is purple and becomes yellow when in contact with CO2. The persistence of detected CO2 after 6 manual breaths indicates tracheal intubation. Rarely, BMV before intubation or ingestion of carbonated beverages may lead to release of CO2 from the stomach after esophageal intubation, causing a false indication of tracheal intubation. Washout of this phenomena occurs within 6 breaths. However, so persistence of CO2 detection after 6 breaths indicates tracheal intubation. Although end-tidal CO2 detection is highly sensitive and specific for detecting esophageal intubation, caution is required for patients with cardiopulmonary arrest. Insufficient gas exchange may hamper CO2 detection in the exhaled air even when the tube is correctly placed within the trachea. In patients with cardiopulmonary arrest, a CO2 level greater than 2% should be considered definitive evidence of correct ETT placement. But the absence of such CO2 cannot be used reliably as an indicator of esophageal intubation. This circumstance arises in approximately 25 to 40% of intubated cardiac arrest patients. In all other patients, absence of CO2 detection indicates failure to intubate the trachea, and immediate reintubation is indicated. The other method of tube placement confirmation is the aspiration technique, which is based on the anatomic differences between the trachea and the esophagus. The esophagus is a muscular structure with no support within its walls. The trachea is held patent by cartilaginous rings. Vigorous aspiration of air through the ETT with the ETT cuff deflated results in occlusion of the ETT orifices by the soft walls of the esophagus, whereas aspiration after tracheal placement of the tube is easy and rapid. Bulb or syringe aspiration devices may be used in cardiac arrest patients with no detectable CO2, but although they are highly reliable at detecting esophageal intubation, in other words, highly sensitive, false positives occur, in other words, poor specificity, and may indicate esophageal intubation when the tube is in the trachea. Aspiration devices may be useful in the out-of-hospital setting when poor lighting hampers colorimetric end-tidal CO2 determination. They are also good backup devices when cardiac arrest confounds attempts to assess placement using end-tidal CO2. Detection of expired CO2 is more reliable and should be considered the standard for confirmation of tracheal placement of an ETT and for early detection of accidental esophageal intubation. Aspiration devices have a valuable secondary role. It is generally not sufficient to perform laryngoscopy to, quote, confirm that the tube is through the glottis because error and misinterpretation can occur, especially if the clinician confirming the intubation is the same person who intubated in the first place. The objective instrument, end-tidal CO2, should be considered correct. In the absence of complete upper or lower obstruction with inability to ventilate the patient with even small tidal volumes, failure of CO2 detection should not be ascribed to other causes such as severe asthma, in which the physician might postulate that adequate CO2 exchange is not occurring for physiologic reasons. Absent of equipment failure, this does not occur, and detection failure should be adequate with intubation failure. A positive CO2 reading also can occur when the tube has been misplaced above the glottis or in mainstem bronchus, where gas exchange can occur despite the lack of tracheal intubation. End-tidal CO2 detection with aspiration as backup should be considered the primary means of ETT placement confirmation. Secondary means include physical exam findings, oximetry, and radiography. The examiner should auscultate both lung fields and the epigastric area. Auscultation of typical hollow, gurgling gastric sounds in the epigastrium is highly suggestive of esophageal intubation and should prompt consideration of immediate intubation for re-intubation. Diminished or absent breath sounds on one side, usually the left side, indicate mainstem bronchus intubation in the absence of pneumothorax or an alternate cause of unilateral loss of breath sounds. Persistent obvious leak despite positive end-tidal CO2 detection indicates cuff malfunction or supraglottic placement of the ETT, such that the tube is in the airway, detecting CO2, but above the vocal cords. In either case, mainstem bronchus intubation or supraglottic intubation, tube repositioning is indicated. Pulse oximetry is indicated as a monitoring technique in all critically ill patients, not just those patients who require intubation. Oximetry is useful in detecting esophageal intubation, but may not show a decreasing oxygen saturation for several minutes after a failed intubation because of the oxygen reservoir from pre-oxygenation created in the patient before intubation. Oximetry may be particularly misleading in a spontaneously breathing patient who has had an inadvertent nasal esophageal intubation. In this case, oxygen saturation may be preserved because of spontaneous respirations, but catastrophe ensues if the patient is later paralyzed or heavily sedated in the mistaken belief that the tube is in the trachea. Although chest radiography is universally recommended after ETT placement, its primary purpose is to ensure that the tube is well positioned below the cords and above the carina. A single anteroposterior chest radiograph is not sufficient to detect esophageal intubation, although esophageal intubation may be detected if the ETT is clearly outside the air shadow of the trachea. In doubtful cases, a fiber optic scope can be passed through the ETT to identify tracheal rings, a gold standard for confirmation of tracheal placement. Approach to intubation. After it is determined that the patient requires intubation, an approach must be planned. The approach is predicted on two key determinations that must be made before active airway management is begun. The first determination is whether the patient is in cardiopulmonary arrest or a state near to the arrest and is predicted to be unresponsive to direct laryngoscopy. Such a patient, if they're agonal, near death, is called a crash airway patient for the purposes of the airway management and is managed using the crash airway algorithm by immediate intubation without use of drugs, supplemented by a single dose of succinylcholine if the attempt to intubate fails and the patient is not sufficiently relaxed. The second determination is whether the patient represents a difficult intubation as determined by the Lemon evaluation. If so, the difficult airway algorithm is used. For all other cases, that is, for all patients who require emergency department intubation but who have neither a crash airway nor a difficult airway, RSI is recommended. RSI provides the safest, quickest method of achieving intubation in such patients. After administration of the RSI drugs, intubation attempts are repeated until the patient is intubated or a failed intubation is identified. If more than one intubation attempt is required, oxygen saturation monitored continuously, and if saturation falls to 90% or less, BMV is performed until saturation is recovered for another attempt. If the operator cannot maintain the oxygen saturation at 90% or greater, or at least stable if beginning at less than 90%, despite optimal use of two-person, two-handed technique with an oral airway in place, a failed airway exists. This is referred to as a can't intubate, can't oxygenate situation. In addition, if 3 attempts to direct laryngoscopy have been unsuccessful, a failed airway exists because subsequent attempts at laryngoscopy by the same operator are unlikely to succeed. The 3 failed laryngoscopy attempts are defined as attempts by an experienced operator using optimal patient positioning and the best possible technique. A further attempt to direct laryngoscopy by the same operator of one of the equivalent experience is not advisable unless the operator identifies a specific situation on the 3rd laryngoscopy that is amenable to correction, justifying a 4th attempt. Also, if the operator ascertains after even a single attempt that intubation would be impossible, example, a grade 4 laryngoscopy view despite optimal patient positioning, a failed airway is present. A failed airway is managed according to the failed airway algorithm. Difficult airway. When pre-intubation evaluation has identified a potential